All right. So we're going to start now. You haven't missed anything, doctor. We're going to start now. All right, guys. So let's begin. So what happened is we had a scenario on a scaphoid fracture. So I'll be discussing it in detail. So what exactly happened? So you had a scenario, the patient came to you in A&E, you're referred to in A&E, and the young guy, 34 years, and presented with shoulder pain. Sometimes the task says shoulder pain. Sometimes it also says like wrist pain. So you have to check it out, what exactly they have given it to you. So what we have to do is take a history, take a focused history, assess and discuss the management with the patient, right? So what is the presenting complaint pain? So it's very easy. What you're going to do is you have to elaborate. So how can I help you, doctor? I've got pain in my shoulder or in my wrist after I fell at work. Okay. So what do? You are going to do Socrates. Site, onset, character, associated symptom, radiation, timing, any exacerbating relieving factor, and any severity, isn't it? So all those questions you're going to ask, right? So the patient is telling that I slipped and fell on my outstretched hand while carrying the tools. This is very important. Whenever you are in the direction of making a diagnosis of scaphoid fracture, the main thing that you will see is the patient fall on the outstretched hand. That is very, very important. So that is the thing mainly going to take you towards the diagnosis of scaphoid fracture. So what you do, you will just complete your Socrates. Patient says it is in the wrist and pain near the thumb side as well, near the thumb area as well. So the patient has those pain in the arm. So it's in the thumb area, wrist, and the shoulder. So this whole area is having the pain. Patient fall down on outstretched hand, right? So after you're done with the Socrates, what you're going to do, you're going to ask other associated symptoms as well. Anything else? Yes, doctor, no, doctor. So what you're going to do, you will ask some associated symptoms. So with pain, I'm going to ask for any redness, any swelling in the nearby area, right? What else I need to ask? As patient had a fall, so what I'm going to ask? So I'll ask, like, if the patient has got any, for example, say jerky movement, any loss of consciousness, if this patient has got. So the couple of these questions, I mean, you can ask. And after the fall, if he was okay or not. So I'm not saying go in very detail, but just a bit of during, before, after, that is something that you can do. Now, patient has got pain. So what else I'm going to ask? Is it only one joint or other joints as well? The patient has got pain. Is it only one side or the other side as well? And also I'll ask if there is any infection, fever, flu-like symptoms. So, when you ask these questions, you are trying to rule out red flags. Examiner will have like, okay, you are thinking in that direction as well. Examiner will see that, okay, you don't have tunnel vision. You're going with the normal vision. So these kind of questions are really, really important, right? So what we did, patient has got pain. You did Socrates. You did a bit of during, before, after. And then what you did, you asked about associated symptom, any redness, any swelling, any fever, flu-like symptoms, and pain in any other joint. These are the main questions that you're going to ask, right? And then quick past personal social history that you need to ask, because patient had a fall, we're suspecting fracture because patient fall down outstretched hand. So what I'm going to see is the things which can cause, for example, the weakening of the bone. I need to try and get those things in the history itself. So for example, have you been diagnosed with any medical condition, any diabetes this patient has got, any medication you're taking? For example, I'm looking for steroid because steroid is going to give you osteoporosis. So those are the questions we have to ask. And you can go for quickly, personal social history as well, whom you're living with, what kind of work you do, smoking. So just quick history you can take. Now somebody asked me, so when I'm going to do the investigation. So once you're done with the history, you mentioned about the examination and you mentioned about the initial investigation. I would like to do your general physical examination. I would like to do your vitals, and I'm going to examine your hand, your wrist, and your shoulder area. So this is something you will say. And I would like to do some initial investigations as well. Which investigation? X-ray of the hand, obviously, and maybe routine blood test. So this is something you're going to mention. Now, another question that I always get is when I should do ice. When is the best time to do ice? I always say you can do wherever you want. Do it for sure. You can do it in the middle of the station when you're not sure what should be my next question. You can do ice. But definitely before you give the diagnosis to your patient, what you have to do is you have to do eyes. So if there is anything you're missing, or if there's anything wrong, for example, you can mention it, right? Now the X-rays. First of all, this case, if you see, this is the A&E scenario, right? So if it is in the GP, what we could have done? Can we do X-rays in the GP? Not really, but can GP order an X-ray? Yes, so GP can order an X-ray. So this patient, usually when the patient had a fall, obviously they're going to go to the A&E, not in the GP. But if this patient came to you in the GP, what you're going to do is you'll be sending this patient to the A&E so that we can do the investigations there, right? Now, okay, so X-ray we have sent, but with this much of history that you have got, patient has got pain, the patient has fallen on like an outstretched hand, what comes in our mind? What comes in our mind? It's a scaphoid fracture. That is what we are suspecting, right? So it's a break in one of the small bones of the wrist, and it's common after falling on an outstretched hand. If not diagnosed or treated, it can lead to poor healing and limited blood supply. So what we have to do is obviously the X-ray, and now see, the thing is, if the X-ray is confirming your fracture, or if the X-ray is not confirming your fracture, to be honest, the treatment is no different. Treatment remains the same. What I mean to say, if X-ray is telling you it's a fracture, what you will do? Immobilize, obviously, thumb spica cast and orthopedic referral, and obviously the patient has got pain. That's my main thing. I'm going to do the pain management. I'm going to give the paracetamol, ibuprofen, or whatever I need to give it to my patient, right? Elevation, ice, and review the fracture in the fracture clinic within a week. So that is my management. Now, if X-ray is negative, but your clinical suspicion is very high because your patient has got pain in the snuff box area, patient has got pain, and patient has fallen outstretched hands. So if your suspicion is very high in the direction of scaphoid fracture, what are you going to do? This management is still the same. You will be treating it like a fracture. You will be still immobilizing it with the thumb spica cast. Nothing is going to be different. And you repeat the X-ray in 2 weeks' time. And if needed, maybe we can consider doing the scan as well. So if you see X-ray is positive, X-ray is not positive, the management is no different. Yeah. So, I mean, and once the X-ray is done, so you will see if the fracture is displaced or not. If it is displaced, obviously, then what we have to do is we have to go for urgent orthopedic referral and maybe surgical fixation and all. We have to do it. Advice to the patient that keep the arm elevated, take the painkillers, avoid using the hand until cleared, follow up with the fracture clearing. So these are the things that you can mention. Any station, make sure you will not finish it until unless you are done with follow-up and warning signs. So tell the patient if your pain is getting worse, if the swelling is getting worse, and you are like struggling to even move your fingers, what you have to do, you have to come to us, you have to come to the A&E straight away or dial 999. So these are the things, I mean, you can mention, right? So that was the scenario, right? So this is what we have got in scaphoid fracture. All right. Okay, so the other one. Your FY2 in GP, baby, Ila, that is, she is 6 weeks old and was seen by the GP and a murmur was heard. Okay. And the mother has some concern about her daughter. Talk to the mother and address her concern. Okay. So you go in and you start the conversation, like, I understand that you have come with your baby and how can I help? Yes, the nurse said they heard something in the heart of my child during the checkup and I'm worried. Okay. So the thing is, she's already been to the hospital and there the check was done, but then she was told that the nurse was able to hear something. Maybe nurse tried to explain things to her, but she wasn't able to understand, and that's the reason the mother has booked the appointment with the GP. Okay. All right. So what you will ask a bit of things of what exactly happened in that consultation. So when was the murmur first noticed, or when you were told about this murmur? So it was like the checkup that happened like 6 weeks checkup. Has anyone mentioned it before at birth or early appointments? No, nobody has mentioned. Okay. See, now what happened is in case of children, pediatrics, murmur. It could be like a normal innocent murmur as well, isn't it? So that is nothing to worry. But before we say this is innocent murmur, nothing to worry, you need to take history, proper history around the child. Like if the child is eating, drinking well, child is playful or not, and if there is any cyanosis, if the child is kind of very much playing and eating properly, any fever, flu-like symptoms, all those questions you need to ask. And murmur is there. So, I mean, cyanosis, as I mentioned, fast breathing, all those questions you need to ask. So, we ask any problem with the feeding, any fast breathing, cyanosis. I mean, and if the child is gaining weight properly or not, failure to thrive, that is a red flag. But no, if the child is gaining weight properly, then it's not a problem, right? If the child is alert, active, moving properly. So, all these are the questions that you need to ask. Fever, flu-like symptoms you can ask, right? So if the child is doing well, there is nothing wrong. You don't need to worry about these murmurs because this is something what we call as innocent murmur, right? Quick, again, past, personal. There's no personal history, obviously, in children, but what you can do is you can ask bird question. How was the birth of the child, immunization status, and the red book, milestones, and the diet, what kind of diet the child is taking, any recent jab. So all those questions you can ask. Who's looking after the child? So all those questions you can quickly cover. And obviously you mentioned about the vitals, general physical examination, and just listening to the heart sounds again. So this is something that you can mention. But mostly in the pediatric cases, you know one thing that you don't have a child simulator in the exam. So we don't have child simulator in the exam. So mostly what's happening, you're talking to the parents. And in most of the pediatric scenario, you will see a line as well, special note that child is in the other room with the nursing staff. Right. But yeah, you can still mention, after taking history, you can still mention that what I'm going to do is I'll be doing a quick examination of your child. Right. That is something that you can mention. So babies, well, as you know, in this case, so what is the management? So what is the management? So you have to reassure. And I would say one thing about PLAB 2, especially pediatric cases. Most of our scenario in pediatrics, they are reassurance stations. Most of them. And this is also one of those reassurance stations. So what you do is you do reassurance, but make sure you give the warning sign as well. At the moment, there is nothing to worry. But what are the alarming symptoms? So you need to give those symptoms as a warning sign, right? So in this particular case, what you're going to do is you're going to do the reassurance. As a child is feeding well, gaining weight properly, and other things are absolutely fine. Nothing called like cyanosis is, I mean, eating, drinking well, and no problem. So everything is okay, right? But what we're going to do is definitely we can refer a child for the further assessment, and we can do further tests, mainly like echocardiogram. So we don't have any further doubts as well. Nothing emergency. It's not like an urgent referral or you have to send the child straight away to the pediatric cardiologist. It's not like that. It's normal review, and whenever the appointment is available, they'll be able to call. But then what you do is, because she's asking what's wrong with the heart of my child, you can simply explain that this is a murmur. This is see, what we called heart, that's very natural concern. What we heard is called a murmur, which is simply a sound made by the blood flowing through the heart. In many babies, especially around this time, we hear these murmur for the first time. Often they are innocent murmur, and they're harmless, and usually the baby grows out of it. As explained, as your child is feeding well, gaining weight, active, and doing everything normally, so it's very reassuring. But what we're going to do, we're going to refer it to the specialist as well, and they'll be able to do a jelly scan of the baby's heart. Echocardiogram, jelly scan, they'll be able to do. So these are the things that you can mention. And meanwhile, just look after your child. But if you see any of the warning sign, for example, the breathing is not okay, poor feeding, cyanosis, not gaining weight, failure to thrive, and fewer wet nappies, murmur is loud, and you can just hear it. So what you will do, you'll just bring the child to the A&E or dial 999. So that is something that you can mention. So again, remember, pediatrics, what they want from you, most of the scenarios are reassurance. But did you rule out the red flags in the questions? Yes, no? And did you give the warning signs for those red flags or not? This is the main thing in pediatrics. Every scenario in pediatrics is a reassurance station. Mostly 99% of the stations are a reassurance station, and this is one of them, right? So this is what we have called in innocent murmur, 6-week-old child. All right. Okay, the next one, acute prostatitis. So we have got a lot of stations in yeah, like for UTI, but some scenarios you'll see for prostatitis as well. And so what are the things that you will see in these patients? So you are FY2 in the GP, and the patient is 40, has got pain in the anal area. So pain in the anal area. And nowadays what happens is most of the station, you also see that they might not give you enough things in the question. You know what they say? You're appointed in GP, patient is Mr. Raid, 40 years, they came with some concerns. Talk to him, assess him, and discuss the plan of management with him. So they may not be giving you enough information as well, which is okay. So if you're given the information outside, I think you can prepare your mind a bit. But if you don't have that information, then you just go in and you'll be able to find things only inside the cubicle, which is okay. Okay, so talk to him, discuss the management. How can I help? Doctor, I've got pain in the area near my bottom. Okay, so any pain, what you're gonna do? As simple as that, you will do Socrates. You'll try to understand what exactly is going on here, right? So the patient says it's a dull pain and it started like a couple of days ago, right? And I feel it's getting worse, right? Does the pain radiate anywhere? Sometimes patients like lower back or the tip of the penis, I can feel. Any burning sensation while passing urine? Sometimes, yes. Because see, now the patient has got pain in the anal area. So what you need to do, you need to ask question around it. That's how I explain things, how I make things easy for candidates is patient has got pain in the anal area. So what you're going to ask, you ask her diarrhea, constipation, UTI, sexual history. All those questions you need to ask, right? So first you do Socrates and then anything else. Anything else like any burning sensation while passing urine, any nausea, vomiting if you have got, any fever, flu-like symptoms if you have got, any blood in the urine if you have got, any frequency, nocturia, right? All those questions. Patient is 40. It may not make much sense if I ask for BPH question because patient is too young for BPH questions. But you have to ask UTI questions for sure, like frequency, nocturia, urgency, nausea, vomiting, fever, flu-like symptoms. Oh, these are very important, right? So ask these questions. Okay, so what else we got? Any similar episodes that you can ask? The medical condition, quick, past, personal, social history you need to take, right? And as I said, UTI, STI, diarrhea, constipation, these are the main important questions for differentials also you're going to ask, right? So when you examine, I would like to do general physical examination, going to check your vitals and what else you would like to do. Maybe a digital rectal examination and routine blood test and urine dipstick test to see if there is an infection, right? So what happened is they might give you some findings sometime. The findings are there on the side on the table, so you can just maybe the patient or the examiner will say the findings are there on the table. You can have a look. Sometimes the examiner will tell you these findings verbally. Sometimes what happens is the examiner will hand over a piece of paper which has got all these findings for you. And sometimes you may have to do the examination as well, right? So in this station, they might be expecting you to do the digital rectal examination as well. So if you do digital rectal examination, patient will have too much of pain. So prostate is tender, swollen, boggy. So that's something you might get. So sometimes the finding is given to you by the examiner, but in this particular scenario, sometimes they are expecting us to do the rectal examination as well. So please make sure you do it. Yeah. So vitals, the temperature is high and rest seems to be okay. Abdomen like mild suprapubic tenderness and urine dipstick is positive for leukocytes and nitrates. Right. So this is infection. But then what kind of infection that we have got here is prostate, acute prostatitis, right? So which is an infection of the prostate gland. This explains your fever and the urinary symptoms that you have got. So obviously what we have to do is we have to do the urine culture as well, culture sensitivity, routine blood, CRP, SR, we are definitely doing that. And then we'll start this patient on the treatment. So treatment is antibiotics. Treatment is antibiotics. And the treatment is done for 14 days in case of acute prostatitis, right? Now, which antibiotic and all, it's okay. If you don't know, that's fine as well. Just simply, it's according to the hospital protocol. Remember one thing, when you're giving antibiotics to any patient, so when you're taking this past personal history, with the history, you understood it's an infection. So don't miss this question of allergy. See if the patient is allergic to something or not. right? So this is really, really important. Patient has got pain, give something for pain. Patient has got nausea, give something for nausea. Patient is having a constipation, give something for that. So just give the symptomatic treatment as well. Okay. Advice, some general advices you can give, and warning sign if the symptoms are getting worse, you're not able to pass urine at all, and the back pain is too severe, just come back to us. So these are something that you can mention, right? So these are the main things. Yeah. So this is what we have got in acute prostatitis. Now, how are you going to be able to find out I'm going to do the examination or not in this particular scenario? So what happened is when you go in the cubicle, I would like you to scan the room quickly and see if there is a mannequin or not. And if there is a mannequin, what does it mean? It means they're expecting you to do the examination as well. So this is really, really important. So you have to be a bit more quick in the history so you can leave some time for the examination and then later for the management as well. Right? Again, the name of the antibiotics, if you know, it's okay. If you don't know, that's fine. You can always say according to the hospital protocol, that is more than enough. And even if your patient asks which antibiotic doctor, it's a good question. I'll just have a look into my book and I'll let you know. That's absolutely fine. And to be honest, as long as the patient knows that you're going to give antibiotics, they're okay with that. They don't usually ask which antibiotic. And to be honest, it's not that important for us to know as well. All right, so this is what we have got in acute prostatitis. Yeah. All right, so the next one, the pain management, disc prolapse pain management. The patient is actually on buprenorphine patch. Buprenorphine is what? It's a strong opioid. Yeah. Okay, so scenario is your FY2 in surgery, GP surgery. The patient is diagnosed with disc prolapse, but that was long time ago. That's 3 years ago. And the patient is using this patch. Yeah, so patient is using this patch, buprenorphine, that is 10 mcg an hour for the pain, and he has got some concern. Go and talk to him, assess him, and address his concern. Right, so disc prolapse. So in this station, I would like you to take history a bit about the pain as well. And, disc prolapse, obviously the patient must have presented with back pain. So now, always hope for the best, but think for the worst for the patient. Why I said that? See, think for the worst. What I mean by that? So when you're taking history, you have to ask for the worst thing. So this prolapse 3 years ago, obviously is getting the treatment and all, but make sure you ask for cauda equina. Or you ask for cauda equina. That is really, really important. Yeah. So that is the main thing. So how can I help you? I've been using this buprenorphine patch for my back pain and I don't really need it anymore. And I would like to change it or maybe stop it completely. Okay, if the pain is getting better, then why obviously we need to give this patch. So what you do, you'll ask a bit about pain as well. What exactly happened, how he got this disc prolapse and cauda equina symptoms if he's having, how's the pain now? And he's saying there is no pain actually. The current pain is nothing, it's just one or two. So Socrates, cauda equina, these are the main things, yeah? And then what you do, you quickly do past personal social history as well, yeah? Once we're done with it, now what we have to do is, so this is a strong opioid. So what are we gonna do? Can we stop it completely or we should taper it down? First of all, we know like the pain ladder, how it goes. First of all, we have got non-opioid plus minus adjuvants, if there is any. And then if the patient is still having pain, we go for mild opioids. That's your codeine and plus minus adjuvants. And then if the patient is still having pain, we go for strong, it's a weak opioid, sorry, weak or mild, whatever you want to say. And a strong opioid plus minus adjuvants. Strong, we are talking about, say, morphine. So that's a basic in pain management, right? So that's a basic thing we see in pain management. So now the patient is actually taking a strong opioid. So what we have to do here, and patient pain is better. So what you have to do is you can taper it down, you can stop it as well, and you can go to the next level. So you have to decrease it. See, always we go up the ladder, but say, for example, post-op, cases or this kind of cases, we have to come down the ladder, right? Remember one thing, whenever the patient is on opioid, we don't stop it abruptly. We don't stop it abruptly. We usually taper it down. Otherwise, the chances of side effects going to be very high. I'll give you another example. We have got a case on medication induced headache. The patient is taking the pain management, so overuse of pain management, and that's the reason patient has got headache. Now, what is the treatment? The treatment is mainly you stop the painkillers abruptly. You stop the painkillers abruptly. That's the thing. However, if the patient is on opioids, what do? You taper it down. So same thing you have to do here as well. So the patient pain is very much controlled. So what you have to do is we will be tapering it down slowly. So you have been on the patch for 3 years and your pain is under control. That's a good thing, but stopping it suddenly can cause withdrawal symptoms. So and the withdrawal symptom like feeling anxious, sleepy, flu-like symptoms, stomach upset, and also what we will do, we will reduce it slowly. Step by step, we will taper it. So your current dose is 10, as you said. So what we'll do, we'll reduce it to 5 and we'll keep it 5, say for example, 3 to 4 weeks. And let's see. So after that, once 10 and then 5, if you are coping well, we might stop it completely. And if not completely, then we might give you some tablets as well, some paracetamol or ibuprofen, or we can come down the ladder as well. So that is something that we can do, right? So that's how we should be going about it. And patient has got what? Disc prolapse. So you can give some general advices about the disc prolapse as well, right? And that is it. And the warning sign for the quad equine. The pain is getting worse. You're having any constipation. You're not able to pass the urine, numbness in the anal area. You're feeling drowsy, sleepy. Just call 999 and come back to us. So these are the things that you can mention. All right. So that's how we go in the pain management. There have been so many scenarios in pain management. Just remember, we go usually, slowly we go up, right? But in some cases, we have to go down the ladder as well, right? And just check the compliance if patient is taking the medications regularly or not. Not in this case because this is patch, so you don't need to worry about it. Another thing, I'll just tell you briefly about the patch. This patient is using for 3 years, that's a different thing. Otherwise, the patch you put on the skin and it takes 12 to 24 hours to show its effect, right? It takes time. It's not like you put it and you'll be pain-free straight away. No, it takes time. It takes 12 to 24 hours. So during that 12 to 24 hours, you might have to give some other painkillers to this patient. That is very important, right? And the patches, usually this buprenorphine patch, you might get it for, there are 2 kinds depending on what is the concentration. It might be working for 3 days, it might be working for 7 days, right? So depending on that. But as I said, it takes 12 to 24 hours to show its effect. So if it is for 3 days, for example, so it's going to work for 3 days. It takes 12 to 24 hours to show its effect, but it's going to work for 3 days. So don't overdose the patient as well. So in the first 12 to 24 hours, you might have to give some other painkillers for the pain management, but later be very careful, don't overdose the patient as well. So that's something that we need to know about the patches, right? So this is what we have got in this particular scenario. All right. So Jehovah Witness, hip surgery. You are in surgery ward. The patient is Mr. Smith, 55-year-old patient, recently underwent surgery for the hip fracture. And now the patient is complaining about dizziness. Patient is feeling dizzy. Other information, patient is a Jehovah Witness and has stated that he doesn't want any, doesn't consent for any kind of blood transfusion, right? His blood shows a hemoglobin level of 55. Right, so that's quite low, and I think that actually explains the dizziness as well. And sometimes the task also said the creatinine was slightly high, which is not something unusual actually. Post-surgery because of kidney injury and all, it can happen, and it's gonna be, I think, gonna recover after that. Talk to him, assess and address his concerns. So it's a Jehovah Witness station, yeah. So the patient is feeling dizzy. So what do? You take a bit of history about dizziness as well. Dizziness means what? Is it like a spinning of the room? Is it like lightheadedness? And once the dizziness starts, how long it lasts? Did you have any jerky movement? Did you lose your consciousness? Do you feel, for example, any sleepy and drowsy, for example? And then you can ask a couple of more questions in before as well, like about the heart racing, and tiredness and eye problem and yeah, all these. So before, during, after, quick history you will be able to take. Yeah, and ask about the fracture thing as well, the treatment, how did it go, and if he's having pain or not, right? Always, any scenario that you get, you have got 8 minutes that you know. So what you need to do is you need to divide the scenario into two parts. First part means you have to gather the data, and the second part of the station is you're giving the information. So gather the data and then give the information. So in this particular scenario, patient has got dizziness. I know when you see the question, it's kind of clear it's because of the hemoglobin, but still your dear examiner wants to see, do you have tunnel vision or a normal vision? So still try just going a bit here and there, and then you conclude the station in the next 4 minutes, right? And then quick past personal history you will be able to take, and then you will explain it to the patient that that we did the surgery for your fracture, and now we did some blood tests, and what we found that your hemoglobin is low and the creatinine is a bit on the higher side. That's your kidney function test, right? And I understood from the notes that you have Jehovah Witness as well. Mostly this patient is Jehovah Witness. This information is given to you in the question. If not, the patient will tell you in the cubicle. It doesn't matter actually, right? Because some of the candidates said it was inside. It was inside, the patient told them. Some said, no, it was given outside the cubicle as well. So it doesn't make much of this difference, right? So the patient is Jehovah Witness. So you can ask the patient is it, so you don't want any kind of blood transfusion, but you can also ask, do you have a trouble or problem with the whole blood, or you are not even accepting the blood products? See, it depends on Jehovah Witness. Some, they don't want any kind of blood transfusion. They don't want any blood products also. But some are okay with the blood products. So our job is to ask this question. You have problem with the whole blood or with the blood products as well? For example, my patient said, I've got problem with both, with the blood, whole blood, and with the blood products. I don't know any of these. Now, patient actually is 55 and patient is having severe dizziness. So what do you think you should be doing? See, we have got some rules, I would say, like autonomy, beneficence, because as a doctor, okay, let me write it here. So we have got autonomy, we have got beneficence, we have got non-maleficence, and justice. These are the main thing that you have to keep in mind while treating any patient. Autonomy, meaning the patient is going to decide regarding their treatment. Beneficence, as a doctor, I work in the benefits of my patient. Non-maleficence, I try my best not to harm my patient. Justice, I'm going to provide the treatment equally and fairly to everyone. Now tell me, the patient is Jehovah Witness, 55 is the HB, patient is having dizziness. You know the blood is the best option, but patient is refusing blood because patient is Jehovah. So what are you going to do? Are you going to give blood? Are you going to go for autonomy, or are you going to go for beneficence? So the thing is, we fully respect the belief of our patient, right? And we document it properly in the file. And remember this line, autonomy overrides the beneficence in adults with capacity. So it's autonomy. Patient has got the right to decide the treatment, and the patient has got the capacity. They have got the right to refuse the treatment as well. So autonomy overrides the beneficence in adults with capacity. Okay, but now what is the option for you? So you have to do something. You can't go for blood transfusion. You can't go for blood products as well. Then what are the options that we have got? So first of all, immediately what we can do is oxygen therapy. So at least whatever the oxygen is reaching to the tissue, so it's going to be a bit more high. So high flow of oxygen to maximize the tissue oxygenation. Yeah, IV fluids. Monitor vitals and positioning like lying flat. So these are the things that could be helpful. Now, if not the blood or blood products, what else? We can go for iron therapy, oral iron or IV iron. That's very important. You can go for vitamin B12 or folate supplementation as well. And we can go for erythropoietin injections as well. That is going to be quite helpful, right? So these are the alternative options that we have got. Also, hematology and renal referral dietitian, these are something that you can mention. Chaplaincy or licensing to ensure patient beliefs are continually respected. What you should avoid, any blood products, as the patient has already said. and don't do an excessive blood tests as well. Obviously, the full blood count and all these things has to be done on the daily basis, right? To see the progress and what else, what next can be done. But rest, excessive blood tests you have to avoid, and avoid NSAIDs and all, because we don't want any kind of bleeding this patient will face, right? So what we do is a fluid balance, I mean input-output chart, and repeat HB every day to see how much iron and how much erythropoietin, so we can go accordingly, monitor the wound site and all those things, right? And give the warning signs as well. If you have got a worsening of dizziness, you get chest pain, palpitation, shortness of breath, and bleeding from the wound site, just let us know. A lot of people ask me, so if the patient is admitted in the hospital, should we give the warning sign? Yes or no? My answer is yes, yes, yes. If the patient is admitted in the hospital, can their condition get worse? Why not? Come on, hospital patient condition can get worse. So tell the patient, instead of saying, come back to us, patient is already in the hospital, my friend. So say, at least say, let us know. So if you get like, if your dizziness is getting worse, you're getting any chest pain, you have got bleeding from the side, please let us know. Or ring a bell. That's something that you can say. Right? So these are the main things that you can mention. Okay. So that's what we have got in Jehovah Witness scenario. Yeah. So another one. So we have got a scenario on aortic dissection as well, and it can come as an in-person consultation, but the last few times when the scenario was there, it was a kind of a tele-consultation. Okay. So sometimes the presenting complaint could be chest pain, but on the other time, maybe the presenting complaint can be back pain as well. So it can be chest pain radiating to back. So patient might tell you back pain and then later tell you about chest pain. Uh, don't get confused. Yeah. So you are FY2 in the A&E, 70-year-old male calling because of chest pain or back pain. Talk to the patient on the phone, discuss the management. See, usually this question also comes to me that in the teleconsultation, who is calling? Is it the patient calling the doctor or doctor calling the patient? Mostly it's doctor calling the patient if it is a GP consultation. So what happened is the patient, they usually call the surgery and they book the appointment, and then the doctor is going to call them at that particular time. But if it is an emergency, it can happen, isn't it? So you have got some, all of a sudden you got some symptoms and you're going to call the A&E straight away. So it can be a patient calling the doctor as well. But most of the teleconsultation that we have seen, it's mainly the doctor calling the patient. Okay. All right. So how can I help? The patient says I was having this chest pain, or they say like it's a back pain while gardening. It started all of a sudden, and something is like it's torn inside. And patient used this word very clearly that it's going towards both the shoulder blades. If it is in between both the shoulder blades and the chest pain radiating to the back, mostly it's going towards aortic dissection. Right, so ask a bit about like patient says in the conversation having chest pain as well. Elaborate about chest pain a bit more. Elaborate a bit more about the back pain. So what we do Socrates, so we get a bit of understanding. So chest pain, you need to rule out some now red flags. As I said, hope for the best, but think for the worst as well. So just ask for other differentials quickly. With the back pain, with chest pain, if you have got anything else, any shortness of breath, for example, nausea, vomiting, palpitation, dizziness. So you can ask about these things quickly, right? And quick past personal social history as well that you can take. Because in past personal history, you may be able to find out some risk factors as well. Because patient later on going to ask you why I'm having this problem. So you'll have something to blame, I would say. So mostly these patients, you will see they have got a blood pressure as well. And you will see they are a smoker as well. Now, don't go into detail of lifestyle history and all. It has to be very specific. So past medical history, quick lifestyle and psychosocial. Who is there in the house? So that somebody can maybe bring the patient in, or maybe somebody can come with this patient in the ambulance as well. Because when you're suspecting aortic dissection, you have to make sure the patient is coming to the hospital straight away, right? But this patient is not ready to come. This patient is not ready to come to the hospital. There is a reason behind it. We'll discuss that. So pick past personal social history and then tell the patient that we would like you to come to the hospital, and what we will be doing will be when you come here, we'll be doing your general physical examination. We'll check your vitals, we'll examine your heart and lungs as well. We'll be doing some blood tests as well when you'll come here, right? So do I says, well, what do you think you have, doctor? The pain is really bad. I feel it's like a heart attack. And then he'll explain it to the patient that information that you have given me, that you have got sudden tearing pain and you have got high blood pressure as well. Smoking history is positive as well. So I'm thinking in the direction of that you might have a condition called aortic dissection. You can explain that we have got a big artery that's coming from the heart. So it looks like there is a tear in that artery. That is the reason that you have got this sharp pain, and if not treated, this condition can be life-threatening as well. So I would like you to come here straight away. So I'm gonna send the ambulance to your house. So that's something that you can do, right? And ambulance is gonna come, and then we will be able to bring you to the hospital, and then the further investigations and all things will be done. So which investigations we're gonna do? Routine bloods. Definitely. UNE troponin, definitely. CRP troponin. Troponin is the main thing that I'm going to do. Group matchings, that is definitely we're going to do. Another thing that you do is ECG, you will do echo as well, and don't forget to mention CT angio. That is the main thing. Patient has got pain, we can give something for pain management as well. We'll check the vitals, blood pressure, higher side. So you may be giving something for controlling the blood pressure as well. So that's kind of a symptomatic treatment. Now, if we found it positive that patient has got aortic dissection, what's the treatment? Mostly it's surgical. Uh, Once you're done with this CT angio, you will be able to find out where is the problem. Is it type A or type B type? So if it is type A, it means ascending aorta, the treatment is surgery, 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 surgery. If it is type B, in the descending aorta, you have got two options. You have to see the patient is stable, patient is unstable. Patient is unstable, what is the treatment? Surgery, surgery, and surgery. But if the patient is stable, then we might have to go for monitoring, ICU monitoring and all. Do we need to mention about this much? To be honest, not really, not really, not really. So what you simply do is we'll be doing these investigations, and based on that, we'll do the treatment. And most of the time, the treatment is surgical treatment. That's something that you can mention. But as I said, this patient is not ready to come to the hospital. The patient is not ready to come. And the reason is like his dog, actually. So you have to do something for that. I can't leave my dog right now. I understand that's a concern for you, but this condition needs emergency treatment in the hospital. So that's why, that's why I asked you to take this psychosocial history, a brief PMH, past medical life, and psychosocial. Who is there in the family, and who is there, like maybe neighbor or so. Maybe you can leave your dog to in the neighbor house for the time being, because your health comes first, because your health is really important, and the condition you are dealing with at the moment is really, really dangerous. It can be life-threatening as well. What are you gonna do? We're gonna scare the patient. That's what we have to do, right? And simply follow up. I mean, and the warning signs and all, you can give warning sign is simply like sudden severe tearing pain if it is radiating to your left arm. And yeah, that's it. And let us know. But that is when the patient is in the hospital, isn't it? So it's a bit tricky. Yeah. So as I said, this station can come as a teleconsultation. This station can come as an in-person consultation as well. Now, how do we diagnose it on the phone call? It was a bit tricky, but then the patient gave the history that I was having chest pain, but now what I feel, it's in my back, it's a tearing pain, and I feel this pain between my shoulder blades. This history is enough to make the diagnosis. Plus, this patient is a hypertension case as well. This is a patient is taking the medication for a very long time as well. So we're not confirming it's aortic dissection, but it is the topmost differential that you have got. Patient is elderly, patient age is 70, hypertension, chest pain, back pain, radiating to back, tearing pain, pain in between the shoulder blades. Enough, doctor, to suspect. As I said, hope for the best, but think for the worst as well. And for this patient, what I'm thinking in worst direction is aortic dissection. And also, see, if my patient came to me and I didn't find aortic dissection, I'm happy my patient is happy as well, right? So that's the thing. But we make sure we're not missing any red flag. Yeah. So that's what we have got in aortic dissection. All right, the next one. Post-coital pain, vaginismus. All right, so scenario is your FY2 in GP. Patient is 36 and has booked the urgent appointment. Talk to the patient, assess the patient, and discuss the management with the patient. So how can I help? So, these kind of stations, the patient might be a bit embarrassed and they may not tell you the things straight away in the beginning. So you just have to reassure, I'm here to help. If you tell me what's happening, I'll be able to help you out in a better way. So you may have to build that rapport, a bit more IPS you may have to show it in the beginning, and then you will see the patient is going to be comfortable and they'll share the information with you. All right. But again, remember there are 3 domains in the exam. History taking, management, and IPS. I've seen a lot of candidates, what they do, they just play around the IPS and they don't consider much of history and management. And they feel, oh, I can talk well, I'm going to pass this exam. It's not like that. You have to fulfill all 3 domains. Then only you can pass this exam. All right. So how can I help? The patient says, I'm embarrassed and all, but then once you do the reassurance, the patient will start talking and the patient says, I'm having pain during sex for the last 3 months. That is the main thing. Pain, what I'm going to do, I'll do brief Socrates here a bit, and what kind of pain it is, where exactly the pain is. Patient says the pain near the entrance in the vaginal area, there is the pain. Okay, so as I said, when the patient has got pain in the private area, so what you do, you ask questions around it as well. So you have to take detailed UTI history, you have to take sexual history as well here, right? So once you're done with the Socrates elaboration of the pain, you ask anything else that this patient has got. So you'll ask for STI questions, you ask for UTI, are you going to the loo more often? You have got fever, flu-like symptoms, you have got nausea, vomiting, any bleeding during after sex if you have got, right? So all these questions you need to ask, right? And bleeding, for example, this is something that you can ask. And you have to go for detailed sexual history as well, yeah? Okay, so then patient already told you that I am sexually active. So you can ask like, are you in stable relationship? Any change in the partner, for example? And this patient said, actually, I changed my partner 3 months ago. You know, this could be a psychosocial trigger for post-coital pain or vaginismus. That's very important. 3 months ago, patient changed the partner. You can also ask if the intercourse is consensual or not. If it is not consensual, then obviously it can lead to pain as well. But if it is consensual, it's less likely. So, but you are trying to rule out the trauma or abuse here. Yeah, that's very important. Do you feel anxious? Do you feel experienced during a tampon use or smear test, for example? So you can ask those questions. So, but this patient says, not really. And I just started having pain just 3 months ago. Before that, everything was absolutely fine. Okay, so what changed 3 months ago? My partner, that's one thing. So the psychosocial trigger, that's very important as well. Yeah. And regarding the smear test, guys, I'm not sure if you're aware or not, the recent change is last month only. There has been a change in the pap smear guidelines. So, you know that initially we used to start from 25 and 25 to 49. Every 3 years we used to do the pap smear. And then from 50 to 64, it was every 5 years it was done. And then more than 64, we were not doing it. We were only doing if there were any abnormal results previously. But these are now old guidelines. The new guideline says from 25 to 64, every 5 years it will be done. Every 5 years. So that's the new one, right? So just remember, you might need it in any other scenario. Right, now when I go to the past medical history, we will find some more interesting thing for this patient. Have you been diagnosed with a medical condition? The patient has got GAD, generalized anxiety disorder. That's really important. Okay, so for how long you've been having it? From last few months, from last 3-4 months only. Because the patient said, actually, I changed my partner, and that's the reason it wasn't going well with the previous partner. That's the reason patient was having this general anxiety disorder. Now patient is with the new partner. So all these things have actually came together. So psychosocial issue because partner is different now, and another is patient is taking the medication for generalized anxiety disorder as well, right? So this is something very important. See which medication patient is taking, see if the patient is taking it regularly as prescribed, any missed dose or not. So all these questions you need to ask in detail. Then I would like to do general physical examination, vitals, and your private area examination as well, right? And do ICE. ICE is a must thing. You can't afford to miss. Right? So the examiner gave you the finding speculum insertion triggers the involuntary contraction of the pelvic floor muscles. There is no discharge, there is no bleeding, cervix normal, but there is involuntary contraction. then this is enough to conclude, and you can always say now that patient has got postcoital pain, which is something we call as vaginismus. Have you heard it before? Not. So it's a common condition. It is a treatable condition where the muscle around the vagina tightens up without you meaning to, right? Often triggered by anxiety, fear of pain, and new relationships. So this can make intercourse difficult, painful, but I mean, your body is healthy. It doesn't mean that there is something wrong. Right. Now, what is the management here? So the management is stop using any soap or perfumed products in or around your vagina if you're using, right? And you use a water-based lubricant. That's very important. Physiotherapy, that's very important. We can refer you to the psychosexual therapist as well. They'll be able to mention things in more detail. They can have a chat with you. CBT, that is something that you can arrange. The patient has got generalized anxiety disorder and patient is taking sertraline. See, there are lots of side effects of sertraline as well. Sertraline can actually cause for example, the dryness in the vagina as well, which can indirectly be the reason for the pain, postcoital pain as well, isn't it? So this is also very important. I'm not stopping the medication on my own. I'm just an FY2. So what you can do is you can tell the patient that we can review this medication. We can refer you to the specialist and we can review this medication. So we'll see. And if there is need be, we can maybe change this medication, right? And then follow up after a couple of weeks, the patient can come for the follow up as well. Red flag, if you've got bleeding after sex, if you've got any discharge coming, any pelvic pain, so just come back to us. So that's how you can conclude this station, right? So a couple of things we got here. The patient is using the soap in around the vagina. Patient is in the new relationship for last 3-4 months. Number 3, the patient is a diagnosed case of generalized anxiety disorder. That also happened a couple of months ago. And patient is on the medication sertraline. That could be the reason responsible for all these things. So find some reasons, mention it in the management, and that is it. So this is what we have got in postcoital pain, vaginismus. All right. Okay, the next one is the plantar wart, Verruca. So the Verruca, this word actually was used by the patient, right? So it's not like we used it. The patient was using this word throughout this consultation. So any skin station, you know how to take the history. I'm not going to go in detailing of it, right? So your FY2 in GP, patient is 57 and having lesion on the foot, on her foot. Talk to her, assess and address her concern. How can I help you? Doctor, I've got rough skin on the bottom of foot and it's been there for a while, and I think it's a Verruca. The patient did use this word Verruca quite a lot throughout the consultation. They're just trying to help you. I mean, they're just trying to tell you like, this is Verruca. Now, most of the dermatological scenario we have seen, they're coming as a teleconsultation. So what you have to see when the task usually says that the patient has booked this appointment, go and call the patient and address the patient's concern, and patient has already emailed you the picture of the skin lesion. So when you go in and you'll be able to see the picture straight away. So when you see the pictures in the beginning, life becomes easy. And as I said, mostly the dermatological stations are coming as a tele consultation, but sometimes it can come as in-person consultation as well. So it's tricky because if it is in person, it may not be a good idea to straight away look at the lesion. I would like you to talk a bit more about the lesion. But when it is teleconsultation, obviously you are just looking at the things on the table, the paper, the picture of the skin lesion is right there in front of you. So that makes your life a bit more easy. Right. I won't show you the picture, but let's see. So the patients have got this skin tag or rough skin, the bottom of it. So what you'll do, you'll elaborate a bit more. Like, tell me a bit more about it. When did you notice it? Is it painful or not? And what's the size of it? If there is any itching, any pain, change in the color, any bleeding, any discharge, any change in the color or bleeding or discharge. So all those questions that you need to ask, right? Now this patient says like, it's painful when I walk. And this is actually in the plantar wart, Verruca. Verrucas are painful because when you put pressure on it, it's gonna be painful, right? Regarding the discharge, they may not have the discharge. So it depends on things, right? Now, when you ask this patient, because this plantar wart, it's not like it's there and is there once you're treated, it's not going to come again. No, it keeps on coming again and again. So when you ask this patient, has it happened before? The patient is like, it has happened many times. Then what you did last time, I just took something from over the counter. It was a spray or a cream. I used it and I was okay. But what happened this time? I tried using it. It's not improving. Okay. Then you may have to go for other treatments and all, right? Now, Verruca. So what are the risk factors? So you need to find out, because the patient already gave it in the hint like it's a Verruca, that's what I feel. So you need to try finding it out, like what are the risk factors for HPV here. So, and obviously the patient is the 57, we're doing with the skin, maybe a couple of questions for red flag, cancer, weight loss, appetite loss. You can ask, that's going to be good as well. Now, swimming pool and using the communal showers, changing rooms, that is a risk factor. Swimming is a risk factor. If you are sharing your footwears, it could be a risk factor. Sometimes in the communal areas and all, you might not be wearing any shoes or any flip-flops. So that could be the reason for getting this HPV infection as well. That's really important. Yeah. So, because what we're trying to find out some risk factors. So we'll have something to blame in the later part of the station. Why I got this? So you have got, okay, this is infection. It can be like, as you mentioned, like you're swimming. So using that communal areas, not wearing flip-flops, and or maybe sharing towels, for example. So that could be the reason as well, right? Then what you do, quick past personal social history as well. Has something similar things happened before? Yes, it has happened. What did you do last time? How long did it take for you to get better? And did you try the same thing this time as well? So all those questions you're gonna ask as well. Another thing, sometimes this patient mentioned that thing also in the beginning, but for some candidates, the patient mentioned that in the later part of the station that I'm retired and now doing gardening. That is also a risk factor actually, right? So for some, a patient mentioned somewhere like in the beginning that it was painful while I'm doing the gardening. But for some, she mentioned in the later part of the station. Okay, doesn't matter. So, and they'll show the picture when after taking history, when you want to do the examination as well, you will be able to have this picture. It's very clear. So then you can mention that what it is. So you do ice. Patient is already saying, I think it's Verruca. So what are you going to say? Yes, based on what you have said and examination I have done, yes, it looks like plantar wart or Verruca. It's a kind of wart that's caused by HPV, right? It commonly appears on the soles of the feet and can become painful when it grows inwards due to the pressure, because you stand on it and it goes inwards. So that's why it's painful. That's the main thing. Right. So it's not dangerous, but it can become uncomfortable. Usually what happens is going to go on its own. But for you, it's been a long time. The patient says, I don't know how long, it's been 2 months. It's been a very long time for you. So what we have to do, we have to do some interventions there. So most verrucas go on their own, and it can take a few months to a year. If it's painful, it's okay to leave it alone, but let your immune system heal it. But since it's painful, then we have to offer some treatment. So offer treatment is over-the-counter salicylic acid. So soak your feet in the warm water first. Gently rub on the top of the verruca with the pumice stone. The stone is it's a rough rock. I think you guys might have used during shower and all. We just use that rough stone on our feet and all just to clean it up, or the foot file. I mean, so gently rub that salicylic acid, and you can use the stone or the foot file to clear it up. So that's something that you can do. And apply the treatment gel, the cream every day, and then you can use the petroleum jelly around it so the healthy skin remains healthy, right? And to prevent the spread, wear the flip-flops in the communal areas, do not share towels, avoid picking or scratching it, all those things, I mean, you can mention. Now, there is another thing in the treatment is duct tape occlusion. It's not mentioned in all the guidelines and all, but patient.co.uk, it's mentioned like covering the verruca with the duct tape can be helpful as well. Some people find it helpful by irritating the area and triggering the immune response. So not very like in detail it was mentioned. So I would advise to go for this self-care option. If that's not getting better, then we can go for secondary option, that is cryotherapy. That's something that we can do, freezing, and then we can take it out if the first line of treatment is not working. And we can review the patient in a couple of weeks time, and we can see the patient early if It's not getting better, it's getting worse. The size is increasing. There's any bleeding, any discharge coming. And if the patient is not able to do the routine things, not able to walk, also come back to us. So that is something that you can mention. But again, as I said, dermatology is mainly about the picture. So if you have got the picture, I mean, in the beginning, if it's a teleconsultation, so you may have the picture in the beginning itself, but even if you find it in the later part of the station, it's fine. So take a bit of history. Another thing, eyes you are doing, so patient might be able to help you. But if it is an in-person consultation, you have taken history and it's not guiding you towards any diagnosis, so there is no harm in looking at the picture early as well, right? Just be a doctor in the room and you will be fine. So this was a plantar wart or verruca, right? Another one is ingrown hair. It's not a very new scenario, I would say. It's been for a very long time, but then we have seen it started coming recently again. The patient, okay, so you are in GP surgery and the patient is 31, has come to you with some rashes, right? How can I help the patient since I've developed a red sore rash in the bikini area? The patients that I went for the Brazilian wax a few days ago, and now I feel I've got this rash in the area. So what you're going to do again, it's a skin station. So you'll be asking the same questions. Tell me a bit more about this rash or the lesion that you have got. When did exactly start? The patient is like, it was after my vaccine. I just did it last week. So ask if it is itchy, if it is painful, if there is any discharge coming, any bleeding coming. Have you noticed any change in the color or any discharge, ulceration, right? And obviously, when there is some lesions, you'll ask if there's any fever, flu-like symptoms or not. So quick history, you will be able to take. Then what you do, you have to take quick past personal and social history as well. And young patient, so maybe sexual history as well, you can take quickly. And as I said, the diagnosis is usually going to be made when you have a look at the picture. So these are the pictures that they'll be able to show it to you, right? So it's ingrown hair actually. So what is it? Ice you will do, and let's see patient says. So you'll explain that based on what I've asked you and the information I've gathered from you and the examination I've done. It looks like ingrown hair. It's quite common after the vaccine, especially in the sensitive area, like in the bikini line, when the hair starts to grow back. So what happens? They sometimes can curl into the skin itself, causing this problem, irritation and bumps. Some of them have get inflamed as well. Management is nothing difficult. Apply a cool compress. Yeah. Paracetamol. Needed, we can give you mild antibiotic cream as well. And wear loose cotton underwear. Avoid shaving or waxing again until the area is fully healed. We could consider giving a mild steroid cream as well. Things are getting worse. We might give you oral antibiotics as well. But prevention. To prevent this in the future, exfoliate the skin gently before and after hair removal to stop hair getting dry. That's really important. And if you shave, do it in the direction of hair growth with a clean razor and use the shaving gel. And you might want to consider hair removal cream or even a laser if it keeps on happening again and again. Right? So these are things. The management is just simply reassurance and maybe mild steroid or antibiotic cream you can give. Right? So dermatology, this is how you can manage. So this is what we have got in ingrown hair after Brazilian wax. All right. Okay, another one. You're a FYT doctor in neurology department, and we've got the patient age 29 is a known case of intraventricular meningioma and has attended for review after undergoing routine surveillance imaging. So patient is a diagnosed case of meningioma and the patient is being reviewed because we are doing the routine surveillance imaging for this patient, and the imaging was done and the patient is here for the report. So the image confirms that the meningioma remains stable. So meningioma remains stable. However, we got incidental revealed a silent cerebral infarct. So Meningioma were there, and there was nothing changes. There was no changes in that. It was absolutely okay. But then incidentally we found there was a cerebral infarct. So there was a cerebral infarct. So we have to see if the patient has got any symptoms of stroke or not. So talk to the patient about this new finding and discuss the management. So we'll start. How can I help you, doctor? I'm here for my report because I had this surveillance scan imaging because I've been a diagnosed case of meningioma. All right. So I've reviewed your scan and I'll go through the results in a while. Before that, I would like to ask you some questions because the patient has got this infarct, right? So you have to ask questions about stroke. Mainly, you have to ask about, I would say, fast symptoms, isn't it? Any facial drooping, any arm weakness, any slurred speech, if you've got any problem with the swallowing, for example, any problem while walking, if you've got, and ask if these things are ever you have experienced, not for very long time, just for few seconds, maybe, because it might be TIA or something. So ask these questions. Ask about these fast questions. Ask about question for stroke or TIA. That's very important. Right. Now, what you do, you quickly go for past personal history as well, because you need to try finding it out, the risk factors as well. Because in the report, you found there is a cerebral infarct, right? And it could be silent, patient was not having any symptom at all, but then you need to do something to prevent it from happening again. So you need to take history, past personal history. So what are the risk factors? So it's simple, like you have got modifiable, and we have got non-modifiable risk factors as well. So non-modifiable risk factors. So for example, the age of the patient, can you change? The sex of the patient, can you change? The family history, can you change? The previous history of stroke or TIA, you can't change those things. But there are a lot of things that can be modifiable as well. For example, if the patient is a diabetic patient, hypertension case, if the patient is having high cholesterol, patient is a smoker, patient is drinking alcohol, patient is not physically active and not having good diet. All these are the risk factors. Some of them you are able to find in the past medical history. Some you are able to find in the lifestyle history. So ask these questions and try finding it out. What can be the risk factor in this particular scenario? Right. So you'll be able to find some risk factor. And now the point is you will start explaining what you have got. So tell the patient that we have, I have done the scan, we have done the scan, the report is there. What we could see is that your meningioma, that those tumors that you have got, it remains stable. There is no change. So that's a very good news. It's a relief sign. But however, I noticed there is something unexpected. A small area of damage in your brain look like a stroke. It's what we call a silent infarct, as it hasn't caused any symptom to you because they've taken the history. That's why in every scenario, what's most important? The most importantly, first you take history. If you straight away, I've seen a lot of candidates straight away just explain that you have got this silent stroke. We found this in the scan and all. Don't do that. First, take a bit of history. So when patient asks you a question, you will be able to answer those questions in a much better way, right? So a stroke happens when blood flow, the part of the brain is blocked, maybe small clot, and this one didn't cause obvious symptom, but it's important because it tells us the risk of having future TIA or strokes, right? So sometimes patient asks, so is it because of the meningioma that I've got? I mean, it doesn't look like, but what we have to do is we have to do further investigations, right? So we have to start the patient on treatment as well, because as we got the stroke, so you definitely need to give aspirin and statin to this patient. Aspirin and statin is a must, right? And another thing, whenever you're starting any patient, not this patient, any patient on statin, what you need to do, you need to do the liver function test as well. LFT is a must. Do it now, do it after 3 months. That's must whenever you're starting the patient on statins, and you start the patient on aspirin as well. Right. Now, which further investigation you think we should be doing? It's a very simple thing. So I would like to do routine blood test, cholesterol level, definitely you need to check. And then I'll do an ECG, I'll do an echo, that's a jelly scan of your heart. What else I'll do? I'll do the neck examination, neck Doppler as well. So these are basic investigations you need to do. And whenever you got anything related to TIA stroke, patient must be seen by the specialist within the 24 hours. So we'll be referring this patient to the specialist as well. So these are the main things, I mean, you have to mention, right? So first, you take a bit of history. You take a bit of history about the stroke, about the risk factors of the stroke, and then explain the patient your meningioma is stable, but then you have got a stroke. And to make sure it doesn't happen again, this is the treatment we are giving, and we are referring you to the specialist, and they'll be able to do further investigations for you. And yeah, don't forget to give the warning signs for fast as well. Any facial drooping, any arm weakness, any slurred speech, it's time to call 999. It's time to call the ambulance. So that's what you have to mention to this patient. All right. All right, then another one is a suspected hip fracture. So you are FY2 in elderly care ward. The patient is an elderly female, 70-year-old, admitted for chest infection, right? Was due for discharge and fell while going to the toilet. Talk to the patient, assess and discuss the plan of management with this patient. Okay, so again, how can I help? Doctor, I had a fall. Okay, so then what you have to do, you have to talk a bit about the fall, and then you have to talk a bit about the chest infection as well. So both the things, I mean, you need to go a bit more in detail. So for the fall, now patient was in the hospital. Yes, in the hospital also you can have fall. So what you need to do, you need to do during, before, after thing. So during which question I ask whether the patient was having loss of consciousness or not. If yes, for how long? Yeah. Then any jerky movement? If yes, you go in a bit more detail. You ask for any uprolling of the eyes, any tongue biting, any urine stool incontinence, you can ask. And if you hurt yourself, for example. After any nausea, vomiting, if you are confused or sleepy or drowsy, do you know things what happened before or after the fall, right? And then before you're trying to find out what could be the reason of this fall. For example, the patient has got any heart problem, for example, any fever, flu-like symptom, because elderly patient, and if you see the patient was admitted because of chest infection only, and the chest infection, any infection in elderly patient is going to be a risk factor for delirium fall as well. So any fever, flu-like symptom, heart problem, palpitations, eye problem, ear problem, you have to ask in before as well. Because what we're trying to find out the reason, right? And then ask for the chest infection as well. How's the chest infection? Patient is like, yeah, it was going well. They were telling me that they're going to discharge me, but then now I got this fall. Okay, quick, past, personal, social history as well that you will take. And mention, I would like to do general physical examination, vitals, and examine your pelvic area, and then send some investigations and maybe this X-ray, right? So the examiner gave you some finding that the right leg appears shortened and turned upward, that is externally rotated. There is clear tenderness over the right hip joint and no visible sign of head trauma or any active bleeding. Okay, so I think with this information, we can mention that it's looking like a fracture. Based on what you have told me and the way your leg looks shorter and turned outward and very painful, I'm concerned that you have a fracture of your hip, specifically the upper part of the thigh bone, femur. And the kind of injury is quite common in the elderly patients. Why it is common in elderly patients? Because the reason is osteoporosis, the weakening of the bone as well. All right. So what is the treatment plan now? So first is obviously we have to postpone the discharge. We can't discharge the patient, right? We'll do an X-ray and if needed, maybe CT scan. If X-ray is making things clear for us, it's okay. Otherwise, we will go for CT scan as well. Patient had a fracture, call your team, orthopedics as well. Patient has got a fracture, pain, so give stronger painkiller as well. You have to be very careful while holding this patient, while managing this patient. If you're changing the position, avoid moving these kind of patients. Otherwise, it can actually make things worse, right? And the treatment is, it depends what kind of treatment we can offer. I think the specialist will be able to tell, is it conservative treatment or they will be doing some surgery with inserting metal screws, for example, or sometime we may have to go for hip replacement, hemiarthroplasty as well. So I think the more information will be shared by the orthopedic team only. So they'll be able to, and physiotherapy followed by it, right? So that's the thing. And don't forget to give the safety netting and follow up. And it is safety netting, like if you feel the pain is getting worse, or if you develop any shortness of breath and all, because PE, for example, that's very, very important for us. That's something that we can mention. Right, so I think calling the specialist team, that is the main thing that we can do for the time. Right, so that's what we have got in this suspected hip fracture scenario as well. All right, guys, so that is it. Let me just stop the recording.